Doctor, I feel dizzy. My hand feels numb. I blacked out for a second. She's not making sense. Neurological symptoms are some of the trickiest words in medicine. Patients use vague, everyday language, but doctors need precise clinical English to know exactly what's happening in the nervous system. Get this wrong, and you can miss a stroke, a seizure, or a bleed on the brain. Get it right, and you sound and think like the clinician you are. In this lesson, you'll master dizziness, weakness and numbness, seizures and loss of consciousness, confusion, tremor, and the 5 words that could save a life, the signs of stroke. Section 1. Dizziness versus vertigo. Almost every patient uses the exact same word. I feel dizzy. But dizzy is not a diagnosis. It's an umbrella term that can hide 4 completely different problems, and your job as a clinician is to unpack it. Vertigo, say vertigo, a spinning sensation. The room is spinning around me, or I feel like I'm on a boat. Vertigo often comes with nausea and nystagmus, involuntary eye movement, and usually points to a problem in the inner ear or the brainstem. Lightheadedness, I feel like I might faint, usually related to blood pressure or blood flow to the brain. Disequilibrium, say disequilibrium. I feel unsteady on my feet, or I feel off balance when I walk. Points more towards a problem with balance, coordination, or the legs themselves. Presyncope, I feel like I'm about to pass out, the sensation right before fainting. Here's how that plays out in a real consultation. Doctors versus patients language. Patient, I feel dizzy, like everything's spinning, and I feel sick. Doctor documents, patient reports vertigo, associated with nausea, worse on head movement. Never write the word dizzy alone in your notes. Always clarify which of the 4 types you're dealing with. It completely changes your differential diagnosis and what you ask next. Useful clarifying questions. When you say dizzy, do you mean the room is spinning, or more like you might faint? Does it happen when you stand up quickly? Is there any nausea or vomiting with it? Section 2. Weakness, numbness, and tingling. Patient, my arm feels weird, like pins and needles, or my leg just won't work properly. Paraesthesia, say paraesthesia, the clinical word for pins and needles, an abnormal tingling or burning sensation. 2 more essential words, weakness, reduced power in a limb, and numbness, a loss of sensation. When weakness becomes complete, we use a different family of words. Paralysis, total loss of movement. Hemiplegia, say hemiplegia, weakness or paralysis affecting one whole side of the body. Paraplegia, affecting both legs. Ataxia, say ataxia, a loss of coordination. Movements become clumsy or unsteady even though the muscles themselves are still strong. Now the critical distinction, the one that separates a routine case from an emergency. Red flag, unilateral, sudden weakness is medical emergency until proven otherwise. Bilateral, gradual weakness is usually a different, less urgent picture, such as a peripheral nerve problem. Ask directly every time. Is it on one side of your body or both? Did it come on suddenly or gradually, over hours or days? Can you still move your fingers and toes normally? Section 3. Seizures and loss of consciousness. Patient, I blacked out, or I had a fit, or I just came to on the floor. Your job is to work out which of 2 very different things happened. Syncope, say syncope, a brief loss of consciousness caused by reduced blood flow to the brain. Usually comes on quickly, resolves quickly, and often has a clear trigger: standing up too fast, heat, pain, or the sight of blood. Seizure, abnormal electrical activity in the brain, may involve a tonic-clonic pattern, stiffening followed by rhythmic jerking, tongue biting, or loss of bladder control. Some patients describe an aura beforehand, a strange smell, taste, or feeling that warns them a seizure is coming. Key history questions ready to use word for word in your next consultation. Did you lose consciousness completely, or did you remember everything? Was there any shaking or jerking of your arms or legs? Did you bite your tongue or lose control of your bladder? How did you feel afterwards? That question matters more than people realize. You're listening for post-ictal confusion. Post-ictal, say post-ic-tul, a period of grogginess and disorientation after the event, which points strongly towards a seizure rather than simple fainting. Quick contrast to lock this in: syncope resolves in seconds and patients recover quickly and clearly. A seizure often leaves the patient confused for several minutes afterwards. How quickly they come back to normal is often the deciding clue. Section 4. Confusion and altered mental status. Family member: she's not making sense today, or he seems really out of it, not himself at all. The clinical word you need is delirium, a sudden change in mental status developing over hours to days. This is completely different from dementia, which is chronic, progressive, and develops over months to years. Doctors versus patients language. Family: he's just not himself today. He keeps forgetting where he is. Doctor documents acute confusional state, onset within 24 hours, fluctuating throughout the day. The single most useful question you can ask a family member is this a new change, or has this been getting worse gradually over time? That one question often tells you whether you're dealing with a medical emergency or a chronic condition that needs a different kind of workup. Other useful phrases are, does he know where he is and what day it is? And has anything changed recently? A new infection, new medication, or a fall?
Section 5. Tremor and abnormal movements. Tremor, an involuntary rhythmic shaking movement. Doctors distinguish between a resting tremor, shaking that happens when the limb is relaxed and still, classically associated with Parkinson's disease, and an intention tremor, which gets worse as the patient reaches for something, such as picking up a cup. Useful question: does the shaking happen when your hand is resting, or only when you're trying to do something, like holding a cup? Section 6. Red flags, recognizing stroke. This is where precise English can genuinely save a life. The international memory tool is FAST. F. Face, facial drooping. One side of the face won't move properly, and the smile looks uneven. A. Arms, arm weakness or drift. When both arms are raised, one drifts downward. S. Speech, slurred speech, or sudden difficulty finding the right words. T. Time. Time is critical. Call emergency services immediately. Every minute of delay costs brain tissue. The most important question in a stroke assessment: when was the patient last seen well? This single question decides the entire treatment window, including whether clot-busting medication is even an option. One more red flag worth knowing: a sudden, severe headache that patients describe as the worst headache of my life. That specific phrase should raise concern for a bleed in the brain and needs urgent same-day assessment. If this helped, comment the word neuro and I'll send you the free PDF. Subscribe for weekly medical English lessons that take you from textbook English to real clinical English. Follow for more Medical English Pro.